It is just a huge honor for me today to be podcast interviewing Dr. Alain Aubé, who graduated from University of Montreal in '84 and then went to McGill for a residency program with emphasis in full mouth rehab and orthognathic surgery. In '95, he went through the full Dawson and Pipier curriculum. Then in '98, he was invited by the Montreal Migraine Clinic to study the effect of occlusal equilibration on tension-type headaches. He presented the results at the prestigious American Academy of Restorative Dentistry in 2000 in Chicago. In 2007, he published an article that led to multiple lecture requests. In 2008, he founded the Canadian Occlusion Institute. Because of his knowledge in the field of joint pathology and its relationship to malocclusion, he was invited in 2013 to present to the Quebec Orthodontist Association, to the International Association of French-Speaking Orthodontists in Belgium, and then to Northwestern component of the Edward Engel Society of Orthodontists. Edward Engel is the founder of orthodontics out of St. Louis. He was also invited by University Evry-Val-d'Isson in France to teach in a post-grad program. He more recently created a video for the University of Louisville Dental School on MRI imaging and dentistry. This past December, he published an article on condylar surface reformation following osteoarthritic damage in the Journal of Contemporary Dental Practice. Dr. Aubé maintains a full-time referral practice limited to diagnosing and treating TMJ pathologies and their consequences and the consequences of severe parafunction. He is also a husband, a father of 4, and 1 grandson and another grandchild on the way. Well, my gosh, we both had 4 kids, so are we both equally insane?
Definitely.
What would you tell some young kids in dental school right now are thinking, I think I'm going to grow up and have 4 kids just like Alain and Howie? What would you tell them?
Be prepared.
And my 4 boys, I've turned into 6 grandchildren. I just got my, this month of August, Evelyn was born on the 28th, and I turned 58 the next day. So now every year on my Christmas, my birthday, the day before my birthday will be Evelyn. So I already told everybody, just change my birthday to, it's only going to be Evelyn's. But hey, I'm so honored to get you on the show. I mean, my God, Peter Dawson wrote the foreword in your book. That just speaks volumes of everything. But what I would ask you is, when I got out of school in '87, there were just 9 specialties. And now there's 12. I mean, they've been growing rapidly. They've added, the basics, oral surgery, endo, perio, pediatric, ortho, pros, dental anesthesia. But they've been adding oral facial pain, oral medicine, oral path, oral radiology. Where would you say what you do fits in? Would you consider it a specialty?
That's a tough one because, listen, I can consider it may deserve to be a specialty. It hasn't been considered yet because TMJ pathology relates to malocclusion, relates to pain, relates to growth and development. It relates to a lot of things. So it's actually sort of a common denominator for a lot of different problems. On Saturday, October 17th, I'm having Drew McDonald, an orthodontist, present on the consequences of TMJ pathology on growth and development and malocclusion and how the orthodontist should treat that. And that's a whole point of view in itself. In TMJ pathology, you got 3 types of patients, basically. See, a lot of people think TMD is pain or TMD is just about pain. Drew is the current president of the New Mexico Association of Orthodontists. A lot of people still think that TMD is just a question of pain. 90% of TMD problems do not lead to pain. So there's 3 different categories of patients for TMD problems. And the first and most important category are children. Growing children have a lot of TMJ pathology that most people are not aware of. I don't know if you're familiar with David Hatcher, the radiologist from California that wrote the big book on TMJ pathology. Actually, 40 American university professors wrote the book. And the book came out in 2016. It's Specialty Imaging the Temporomandibular Joint by David Hatcher and Danya Tamimi. That book shed tons of light on what's going on in the joint in young children. We weren't aware that there were so many problems, and a lot of the growth and development issues in the joint actually translate to malocclusion and other problems. So Drew's going to be speaking a lot about that. So that's category number one. And they're usually or typically not in pain. They'll be in pain after the ortho years, around 16, 17, or 18 years. That's when some of the kids do get some pain. Second category of patient is the grown-up that just has a asymmetry or has a retrognathic jaw and doesn't have any pain, but is wearing down their teeth because the bite's off. And just to be clear, I'm not necessarily associating the fact that the bite's off and parafunction. It's a lot more subtle than that. Maybe we can get into that later. The third category of patients are the patients that do have pain. But they're actually about only 10% of the amount of patients that have TMJ growth and development issues or degradation issues. So they're really only a subset, and most of the attention has been given to them because they complain of pain. So when you start looking at this, and I've been doing TMJ pathology for 25 years, and when you really start looking into this, you start understanding that when the pain gets to the patient, you're way far down the line. You're not at the beginning of things. You're at the wrong end. It's just the same with decay. If you wait till the tooth hurts, you need an endo, you need an exo, an extraction, an implant. When the TMJ starts hurting, typically you're far down the line in the problem.
Okay, just summarize that again real quick. They're TMJ or TMD pathologies. What are you calling? I know, a lot of people.
TMD is typically defined as a pain pattern problem. TMJ pathology, which is TMJ growth and development issues or degenerative issues, relates to everything that can go wrong with a temporomandibular joint. Now, you do not have TMD without preceding TMJ pathology. That's in the literature. That's been known for years. But how does a growth and development issue or pathology lead to pain? Well, that's been a great source of debate, because some people develop pain and some people don't. That's when you get the stress issues and the hormonal issues and a lot of different other issues.
I remember, and I know there's a lot of controversy on the psychology, like if you're stressed out.
It's part of the problem. When a person comes in with TMD or anyway, any type of myofascial pain or temporomandibular joint pain, you have to consider both the diagnostics and the pathology and the psychological level of the patient, or wherever they are. Because a lot of those patients that are in pain are stressed out. A lot of them are on meds. A lot of them have emotional issues, but not necessarily all of them. So there are different factors to these patients. There's different facets to the problem.
I still want to stay back with that, especially because I always am telling dentists that they're too dentist focused. They're not consumer focused. And if you were a patient, if you were a consumer and you were on the internet in Montreal, Toronto, or Phoenix, and you were looking at these specialties: oral surgery, endo, perio, pediatric, orthodontics, prosthodontics, dental anesthesia, oral facial pain, oral medicine, oral path, oral radiology, dental public health, do you think they would navigate to oral pathology or orthodontics? Or do you think this really needs to be? If you were King Tut, would you make this a specialty, or would it be covered under oral facial pain?
No, not under oral facial pain. Technically, we should be under orthodontics.
Okay, well, that's a whole can of soup right there. That's a whole show right there. Why would it not be under oral facial pain? And of the 10,000, we mail every orthodontist, 10,800 orthodontists, OrthoTown magazine every month. What letter grade would you give them on occlusion? Some people think they do a great job. Now there's clear aligners, so why would it not go under oral facial pain, and how would you grade the overall specialty of orthodontist in the United States and Canada?
You just gave me a noose to hang myself.
Oh my God, it's true, right?
Okay, so let's try this and without getting tomatoes thrown at me. On one side, I would not put what I do into strictly orofacial pain, because most of the TMJ pathology problems that lead to consequences are not pain patients necessarily. So again, the pain patients are only a subset. So orofacial pain is one thing, but the pathology leading to degradation, leading to airway troubles, leading to headaches, leading to malocclusion, leading to a lot of degradation on the teeth and periodontium, that's another subset of patients. And sometimes patients walk in with everything. Now, so that's a quick answer to that. We could talk hours about just about that. But if we're going to talk about how orthodontists rate in occlusion, well, having been around and having seen great orthodontic work, some of them are fantastic. I'm in a study club with a guy called Bob Caspers out of Detroit Mercy, and he's doing research, and he's just fantastic at how he controls his occlusion and the TMJ pathology. Drew McDonald, I invited, he does the same. They control things absolutely fantastically because they have a sense that the system is a system, starts at the joint, and that occlusion depends a lot on what's going on within the joint. So that's why I think that, since the Tamimi Hatcher book is out, TMJ pathology is now being taught in a lot of orthodontic faculties. So a lot of orthodontic schools are now teaching TMJ pathology because it's at the root of a lot of their problems. Not all their problems, but a lot of them. Subgrowing condyles are a pandemic. Sorry for the word at this time, but they are.
The what's at a pandemic?
Subgrowth of the condyles. A University of Alberta study came out in 2000 in the Angle Orthodontist, signed by Brian Neville. Brian and David Hatcher were together on this, and they demonstrated that in a pre-orthodontic adolescent sample, 90% of girls and 80% of boys have at least one displaced disc at age 15. We're dealing with populations of displaced disc people, and a lot of those displaced discs are related, let's not use another word, let's just say related with or come at the same time as condylar undergrowth, leading to either asymmetry if it's on one side or a retrognathic mandible if it's bilateral. So having a displaced disc can actually impair condylar growth. That's been demonstrated, and that's what's coming out now. This is a little ahead of the time for the conversation, maybe, but that's what's coming out, and that's what's in Hatcher's book.
So take me back along your journey. So you come out of school, you see all these patients that need root canals, fillings, crowns. What motivated you to chase down this specialty to the level that you had? I mean, did your mom have this? Did your wife's? What motivated you to just chase TMJ?
Frustration in dental school. I mean, what did you learn about occlusion in dental school? I mean, you and I graduated just a couple of years apart. What did you learn that was absolutely great in occlusion in dental school? I don't know about you, but we didn't learn that much. It was like, okay, you can do this, you can do that, and there's not much to learn, and you do a splint, and what's the effectiveness of a splint? Well, half of the patients wear them, half of the patients don't. Ends up 80% are in the drawer after a year. It was just frustration that I didn't learn anything that was truly intelligent about occlusion in dental school. Then in my residency program, we went a lot further. Then we went into seating joints. Then we went into anterior guidance. And this was sort of, we did perioprosthesis back then, the Morton Amsterdam theories that from the 1970s. So at the Jewish General, where I did my residency with McGill, we were into perioprosthesis, we were into full mouth rehab, taking care of periodontal problems, and getting the occlusion spot on. And that would help the patients get their bones straight and get their periodontiums good and get them comfortable and get the joint pains away and the muscle tension away. And we did great with patients back then. We weren't totally understanding everything we were doing, but we were advancing. We were years ahead of what was going on in the dental faculty at U of M. But this was a residency program with high-end professors. So down the line, I started into general practice, and I was in general practice for a number of years, doing splints and doing things and doing a little bit of rehab, and still there was something missing. And then at one point, somebody came up to me and said, "You should go to Peter Dawson." So I went to Pete, and that was just illumination. So I went to Pete in the mid-90s. Pete introduced me to Mark Piper. And I did the full curriculum with Pete, full curriculum with Mark Piper, and that really kicked it off. That I started understanding how occlusion works, started understanding how the joint works, how they relate, the pathology in the joint, how that creates occlusal problems, and that's how things got started. Then I started having answers for my patients. Then things started going well. Then I could do something that was intelligent and relevant for the patient. Then I went elsewhere. Then I went to almost everything I could find. I spent a lot of time with Jeff Okus in Kentucky, and I spent time with the American Association of Craniomandibular Pain, and I went to a lot of different places. And it's just that in the end, once you've been around, the pathology, the joint pathology is the source of most of the troubles. So you have to concentrate on that first. Once you got that down, and then you understand the occlusion, how those two relate, then you can get to the pain patients. Then you can include the stress levels, and then you can include all the rest. But so that's sort of how all of that happened. But it was frustration of not being taught something I could really use, and being face to face with my patients and being in trouble or in facing problems I did not know how to solve.
So Pete Dawson, 1930 to 2019, we lost him last year, a great legend. What did Peter Dawson mean to you?
He was my dental dad. Can I say that?
Yeah.
He was my dental dad. After dental school and after, I do suppose you've met Pete. Pete was a father figure. He too was a father of four. And he was a true father figure. And he's the one that had me present. He was president of the American Academy of Restorative Dentistry the year I presented. He was the one that invited me to present. So he was a father figure to a lot of people, and he was a father figure to me. I mean, and I don't want to insult his kids by that, but he was a father figure to all of us. And he meant the world because of his passion, the way he did things. I mean, he was right about a lot of things. I mean, there are details. Science is advanced, and there are things that have changed, and we understand that, and that's okay. And of his own words, he said, I'm saying what I think is true today, but in 10 years, what I'm saying today might be all wrong. And I want you guys to know that and to change if it does happen. So we're evolving.
Do you think oral radiology has been a big change? I mean, I've seen some crazy stuff where you would have never, ever assumed anything, and then you see CBCT, and there's like some little ball crystal right there in her joint, so has it made a big impact on you and the profession?
It has made the impact because I do a little bit of CBCT, but I mostly MRI the joints. So you know where the disc is. You know if the marrow of the condyle is inflamed. You know if it's perforated. You know if there's inflammation in the pterygoid muscle or around the joint or around the condyle, superior space, inferior space. You know what's happening in the joint with an MRI, a lot more than with the CBCT, but they're complementary. So they complement each other.
Okay, so when you say you prefer an MRI instead of a CBCT, are you sending them out for MRIs?
Definitely. Not all my patients, but right. About 10-15% of my patients I will send for an MRI.
And explain to the kids why. Why do you do that? And what's the difference between an MRI and a CBCT? And why do you prefer the MRI?
Well, for me, for my practice, the MRI gives me a lot more information. The CBCT will give you the bone, the bone quality, and it'll tell you if it's osteoarthritic or not. It will give you the position of the joint. Those things are good, but it's not the complete picture. Your picture of the joint is not complete without an MRI. If you look at radiology articles, you'll see that medicine radiology articles, MRI is the gold standard. And there was an article out about, I think it was 2014, about done with 10 different medical radiologists who concluded that MRI was the gold standard, even for the temporomandibular joint. The article was in the World Journal of Radiology. Asim Bag signed that one, BAG. So if you want to look that up. That was a great article because it summed up all the pathology within the all the pathologies within the temporomandibular joint. And this was done by medical radiologists. So they agree on what we know in what we're doing and know in joint pathology. So why MRI? Just because we get a lot more information from it. See, CBCT will give you the present status of the joint, will not help you with prognosis. MRI can tell you more about the past and more about the future. Let me put it that way.
Well, did you like how much are these MRI machines that you're sending out for? I mean,
the machine or the cost of the MRI?
No, the cost of the machine.
Well, machines in Canada for a 1.5 Tesla regular machine is about 1.5 million.
For the MRI.
Yes.
Yeah. So, I mean, it's just out of reach for that. But did you also buy a CBCT for in your office, or do you refer those out too?
I have a great oral maxillofacial radiologist just across the street, so I send them out.
Yeah, and you know what? It really is strange to me. They always complain about their $400,000 in student loans, but they buy a $100,000 CBCT that they don't need. If every doctor I go to sends me somewhere else for an image, they don't have the machines in house. Furthermore, look at your phone. What's the longest you've kept your smartphone before you upgraded it?
Was it 2 or 3 years, maybe?
I know. So, I mean, every 2 or 3 years, you're like, you upgrade and now they bought this $140,000 CBCT, and they want to get the most money out of it, so they want to own it for 30 years because it's paid for, and it'd be like 30 years now, it'd be like a Nokia flip phone made or Motorola. But so do you, are you exclusively TMD?
Yes.
And what do you call? I know if you say TMJ, dentists get mad, whatever. But I just want to tell the dentist straight up one thing. Dentistry doesn't exist until a human gives a dentist $1 and says, "Will you help me?" And it started off in France. Who was the? Oh my gosh, I can't believe I forgot that guy's name. But who's the guy who started it in France?
Yeah, I got the name of the yes.
Not
Fauchard.
No, not Pierre Fauchard. The century before him. They really got it going before him. Let me.
Then you lost me.
Let me find it because. But anyway, there it is. It was Ambrose Père, 1510 to 1590. Was a French barber surgeon. His philosophy was meaning the physician cares while nature heals or whatever. But he's the guy who started the track. This was different. And then Pierre Fauchard picked up on it and took it to another level, then G.V. Black or whatever. But dentistry doesn't begin until a patient walks up to you and says, "Will you help me?" and gives you a coin and you take their teeth. So when endodontists try to change root canal therapy to endodontic therapy, that's insane. If all the patients call it TMJ, it's TMJ. I don't care what the doctors with 8 years of college want to call it, because they'll call it something Latin, Greek, whatever. I mean, it's all about the consumer, the patient, and that's what they're there for. And by the way, when I lectured in France, the Pierre Fauchard Museum was closed to be remodeled. I'm like, what is the chance of that? I go to France, I take 3 of my 4 boys with me, and the damn only thing I wanted to say, I had to go see the Mona Lisa because this was closed. But you think imaging has been a game changer?
Absolutely. It's helped us to understand what's going on.
And why don't you just send it to an oral radiologist so that you don't have to buy a 6-figure machine? That, I mean, I don't know. Would you recommend? Do you recommend that? Would you say that? Just send them all out?
Well, I can see that a person using the machine every day, doing implants or doing orthodontics, would want to have one in-house. I can understand that desire. I'm not sending them all out, and I don't need them for every patient. So I can just use my radiologist across the street, and it's good for me. So I'm not putting in implants, and I'm not doing orthodontics. So I don't need them for every single patient. If I was an orthodontist, though, I'd probably want one in my office. And if I was doing implants all day, I probably would want it with me close by to take new images whenever I needed them. But for what I need to do with it, the radiologist is across the street, and she's absolutely fantastic. And her machine's great, and she gives me fantastic reports.
So who's calling you up and coming to you? I mean, the jokes about TMJ is it's always the crazy, stressed out lady, you know what I mean? And you would never want to be a pediatric dentist because it's just a bunch of screaming kids. And you never want to go to TMJ because it's all going to be a bunch of crazy ladies with crazy eyes. Where does that stereotype come from? I mean, it came from somewhere.
Well, it comes from the fact that people that complain are usually so far down the line, they're in pain, they're depressed. The pain patients often have anxiety issues. And the ones that complain the most are those that are either depressive or have anxiety issues. So these patients are the worst nightmares for the dentist because typically they're not made for us because we're not psychologists or psychiatrists. They're not for us, but we have to treat them because they have the pain within our sphere of knowledge. So with those patients, you have to work with psychologists. You have to work with our physicians. You have to work with meds that are out of our hands. The origin of this is because the first patients that used to complain of TMJ problems were on the crazier side. That was true. But again, when things start off, you get the worst patients. Like 10 years ago, when I limited my practice to TMJ problems, I got all the crazies. And that was true. It was a tough time. But what I'm getting now, because I'm educating the dentist around me, I'm getting preventive cases. I'm getting children that are sent to me to assess the TMJ level of problem. Is the disc reducible? Is it not? Is it going to grow? Can I use my
I gotta stop because I'm well aware a quarter of my listeners are still in dental school. So when you use terms reducible, that went pshoo.
Okay.
So slow down, Spanky, and explain what you just said.
No problem. All right, thanks. Thanks for slowing me down. In the joint, we all have a disc. We should all know at least that much. The disc in a bunch of kids and adults, of course, because it doesn't go back into place, is displaced. That's what we thought. That's what we used to think was not true. We used to think that most people had their joint discs in place. That is not true. I have 2,400 joints in my database. 2% of them have a disc in place. 98% have displaced discs. Okay, I have a special clientele, but if you do it at large, like Nebby and Hatcher did, you will find at least 80 to 85% of the population does have a displaced disc. Now, discs displace a little bit, medium, a lot, or a ton, basically. But a little bit, you don't hear a click. A little bit more, you can hear a click. What does that mean? It means that when you open your mouth, the disc that's a little bit ahead of the condyle, well, when you open your mouth, the condyle slips underneath the disc, and that makes the clicking sound. So that's the click. You're actually recapturing your disc, and we call that reduction. So that is a anterior disc displacement with reduction. If your disc is set further forward, if the retrodiscal tissues have stretched more or they're thinned out, your disc is further out. And at one point, the condyle, when you open your mouth, just pushes the disc even further. So you stop hearing a click. So your classic patient that says, oh yeah, doc, I clicked for years and just stopped clicking 2 weeks ago and I'm fine. Well, that patient isn't better. That patient is worse because now they're only functioning on their retrodiscal tissues, and that may thin down, and you can eventually have osteoarthritic damage because you have a perforation there. So a reducing disc is when the clicks, and a non-reducing disc is when the condyle just pushes more forward and they get thinning of their retrodiscal tissues, and they're at risk of having perforation, bone-to-bone contact. But there's a ton of those out there. The youngest patient I have on MRI of having a non-reducing disc, so a fully displaced disc, is 7 years old. And they have perforated tissues. That kid has perforated tissues and is having a totally arrested growth condyle. So one condyle has the disc and is growing, and the other one has stopped growing because the disc is totally out of place. And that kid is starting to have osteoarthritic damage, and she is 7 years old. And where do you think the chin is? If one condyle is growing and not the other one, she's way out to here. So we used to think that was, okay, that's asymmetry. But where does that asymmetry come from? And can that be, can an orthodontist use a bionator or something else to stimulate growth? When the disc is still a little bit in place, you can get some growth. But if it's not in place, you're just going to harm the child even more with your appliance. And that's been tried and tried again. So these are things that people have been sending me to assess the state of the joint. I mean, I get referrals from general practitioners, but I get referrals from prosthodontists, from orthodontists, from a lot of surgeons, because they want to assess what the status of the joint is before they do some sort of major intervention.
So one of the things that scares a lot of the people listening to you right now is that, should they change the bite? Like when they're doing like a denture, there are a big case, they're frightened that they might change the bite. And if they change the bite, that will cause all the TMJ and TMD. What would you say to that?
Well, if you're changing someone's bite and if they have both discs in place and TMJs are fine, you're not going to be causing a problem because the TMJs, that person's TMJs are resistant, their discs are in place, things are good. I mean, you're not going to have a knee problem if your meniscus is in place and you go walk a mile or two. That's not going to happen. So changing a bite with healthy joints is not going to be a problem. But a person with healthy joints is a rare occasion. So yes, changing a bite to another bite that you're not sure the patient's going to tolerate, well, that can be a risk factor, but you have to know what you're doing. So that's when knowing what type of occlusion, see, there's a consensus now of what type of occlusion creates the least amount of effort from the muscles and from the joint. And I have to underline what I said because that's what I said and that's all it meant. If you have what Pete always taught and what Pankey teaches and what the prosthodontists teach, you seat the joint, you seat the teeth, canine guidance, anterior incisal guidance going forward. That is the occlusion that will generate the least amount of stress on the muscles and the joints. Now, will that cure everyone of everything? No. Is that tolerated by most people? Yes. So if you want to change an occlusion, you should go to what the prosthodontists almost all do now, seat the joint, make sure the TMJ isn't inflamed, make sure it's stable, seat the joint, seat the teeth, canine guidance, incisal guidance, and you're good. That's what Jeff Okeson teaches, that's what Dawson teaches, Pankey teaches, that's what most people teach now, because we know that this is what, that's what generates the least effort from the muscles and from the joint. Doesn't mean it heals everything, but it's the best situation for long-term use and for calm in the system. Now, there are other occlusions that can be tolerated by this patient or that patient, but if you're doing guesswork, you're doing guesswork. So you got to know what you're doing. You got to understand your joint. If you're going to change a bite, you got to understand the status of the joint. If it's healthy, stable at least, or if it's pathologic. And if it is pathologic, you have to know what to do to stabilize it before you do any prosto on the patient.
Okay, so how many, you have 4 children. How old's the oldest child?
She's 29. She'll be 30 in 2 weeks.
So, my God, my oldest 32. So here's the exact problem. She graduated from dental school, and she's 25 to 30, and she only became a dentist because of her mom or dad. And she's in there in her parents' practice, and anytime anybody has a TMJ anything, her dad just calls the assistant to run over there, take some alginate, send it to the lab to make an upper splint, and then it'll come back in a week, and then the assistant tries it on, and then comes the doctor and says, I need a check, and he goes in there and bites down twice, and that's TMJ. I'm telling you, that's how over half of all TMJ is treated in America. And then a follow-up question to that, some of them will throw in pharmacology and write them a prescription for, Valium or something. So I guarantee you that's how half of America works. I don't know about Montreal, if that's the same, but but she's trying to, it's her mom, it's her dad. She's, and how would she talk about this with her mom and dad? How would you try to get, what does the millennial do when that's what mom and dad do and have always done? And,
Well, that young,
do you agree? Do you agree with that?
Absolutely, Howard. This is you just named the game. That is the issue. Of course, your experience in dentistry, this, but this is absolutely the issue. Listen, the reason the Canadian Institute was founded, Canadian Occlusion Institute was founded, is exactly what you said. What is being done is not up to par with today's knowledge. People try things because that's what they learned in dental school, but it is very basic knowledge. Yes, sometimes it does help, but a lot of times it doesn't. And a lot of times it does make the case worse. So what that young dentist should do is get knowledge. If they want to come to the Canadian Occlusion Institute, they're welcome. I'm doing something now. I'm preparing something for the States. It's going to be called Starting with the Basics, and that's not out yet, but sometime it will come out.
Okay, so that site's not live yet, but you said the other one was Centre Dentaire. It's in French. Sorry, my French is.
Well, just do Canadian Occlusion Institute. You'll find it, or ICO,
it'll go. You got a website in English too. The Canadian.
Yes. Yeah, both my clinic and my school website have both versions, French and English.
Okay, so you the same website. You just go.
And they're linked. You go to one site.
Okay, I got it.
Clinic. The sites are linked.
Okay, so tell them what that is. Okay, so if you go to the website is ICO-Institute, INSTITUT.ca for Canada. So that's the website that you're talking about, right?
That's my main website for the school.
And tell them about your school and how they would learn more.
Well, when they come to us, they get the basic. I teach now in the province of Quebec with Pete Dawson's blessings and Mark Piper's blessings. Both of them gave me permission to use their material and to teach the dentists in Quebec in French about everything I had learned from them about occlusion. And the reason I did that is that a lot of people from Quebec were not going to Piper and Dawson. And this was a number of years ago, of course. This was about 15 years ago. And now things have evolved a lot. And a dentist that would come to our courses will get the basics on how to do a proper splint. A splint the article I published in last December about condylar reformation, I was able to do that using a splint that reduces the level of pressure within the joint. And you just have to understand how that works. You have to understand what the problem is. So I'll tell you about that. I'll tell you how to understand how the occlusion works and how to make a splint that's going to be relaxing for the muscles, and it's going to take a little bit of pressure off that joint so the joint can adapt and maybe heal a little bit. And then we're going to talk about occlusal principles, which is basically the same as Dawson and Pipier teaching. And then we'll go into TMJ pathology, and I'm going through the basics of what Mark Piper teaches about the pathology of the joint and basically how to treat minor beginning problems. So if you come to the first 3 courses, you're going to learn a lot about how the system functions, and you're going to be able to adjust your bites a lot better doing anything, doing implantology, doing regular crown and bridge, doing just a filling. You're going to learn.
I gotta back up a little bit because I know where they're at on that journey, and the first fork in the road they're going to come to is they're going to, and I saw this live when buying a car. This person my sister was totally going to buy the car, and she loved it. And then the guy said to her, she goes, I just love the sunroof. And he goes, well, actually, that's a moonroof. And then my sister's all confused, and she was paralyzed because then she didn't buy. She had to go back and talk. She had to go back and talk to her other friend, which one was better. And I thought to myself, from a sales point of view, what the hell would you do that for? Why would you confuse the person? But anyway, the first thing that's going to confuse them is whenever they hear occlusion, they hear there's this neuromuscular or the other kind. So, so she's at a fork in the road. What would you call your kind? Versus if neuromuscular is neuromuscular, what is your kind called?
I don't know if it has a name.
Panky Dawson.
Yes, you could call it Panky Dawson. Yes.
Yeah. Would you call it traditional or whatever?
Well, that side is now what most prosthodontists are doing and teaching. And that is what Panky and Dawson, both the institutes, are teaching now. And that is what is most popular now.
Okay, well, explain to her why she should learn Panky Dawson occlusion versus neuromuscular. What's the difference? And that's first.
I learned both. I went to both sides of the story because I was going to teach. I need to learn and understand both sides of the story. Back when I went, which is 2006, 7, and 8, what I saw on one side to me was making more sense than what was on the other side and was definitely more complete. Now, I could not speak about what's being said or done today. But back then, definitely what was going on in the Dawson Panky corner was definitely much, much more complete, especially that I had all the joint issues. And when I went to the other side, I was actually asked as a student there to teach them about the joint because they were not knowledgeable about the joint pathology. So actually, I was a student there, and there were questions from students that only I in the room could answer. So that sort of confirmed to me that my education was more complete.
So when I go to your website, www.ico, and that is Institut Dental. Well, what is that in French? It's the French, right? ICO, Institut Canadien d'Occlusion. Is that how you say it?
Institut Canadien d'Occlusion.
I do remember. I only learned. This is all the French I know from one date. She taught me "Je t'aime ma femme."
That's perfect.
Yeah. What does that mean? I love my wife.
Yes.
Yeah, and so that's the only French I know. I'm sorry. So the website stands for ICO, Institut Canadien. Is it d'Occlusion?
Yes.
I mean, but there's a D in front of it. How does that sound?
Yeah, D with that little apostrophe. Is that how you say it in English?
Yeah.
D apostrophe occlusion. D'occlusion.
Okay, so that's ICO #Institute. And you go there, and you're going to see that the courses. So you have the basic level 1, intermediate level 2, master's level 3. So base level course 1 is effective bite splints, and course 2 and 3 are effective occlusal adjustments.
Yes.
And then the intermediate level is course 4, determining the stability of the TMJ for everyday practice. Course 5 is imaging. And then the master's level is advanced occlusion and advanced TMJ. And then he runs a parallel curriculum for staff for basic, intermediate, masters. And then they have other courses for everyone. So the logistics. So you have 1, 2, 3, 4, 5, 6 courses. Do they? Should you take them in order?
Yes, definitely. Yes, absolutely.
Okay.
Yes, if someone wants to come to Canada to do the courses, yes, definitely they should take them in order.
And do they need to be there physically, or can they also do it online?
Well, that's what we're starting to do now. Since COVID, we've been doing a lot of Zoom presentations, and as you can see, they work absolutely great. They're fantastic. So we are now preparing all the courses to be done online. So we're actually doing that now. And that's where the other thing, starting with the basics, is going to be, because I'm going to be doing both in French and in English for the Canadian and American market.
And when do you think that will be done?
Hopefully, we're aiming for January. It's the film people have told me it's going to take 2 to 3 months to film and edit. So we're aiming for January.
I think the best marketing, Pinky Institute did this and Dawson did this, where they have a 1 week course, and it's a big disconnect to go from, I read an article, to a week-long course. So what they did is they put a 1 hour, Dentaltown has 400 1-hour courses. They've been viewed 1 million times. You should make a 1 hour course of your philosophy, all that kind of stuff. And then that is the intermediate between, that'll be, they can meet you, they can like you, they can, all that stuff, and then that will lead them on. I mean, my job is to try to motivate them down the road, and I think if you're going to make all that material, you got to put the first hour on Dentaltown. That'll help with the journey.
Please do so, of course.
Another question I have is, some people say dentistry is 3 things: caries, perio, and occlusion. And a lot of people wonder that why do the dental schools, why do they teach caries and perio so much better, but not really occlusion? Why is that still? I mean, it doesn't seem like it's changed since I got out in 1987. It still seems to be the weaker of the 3 kids in the family coming out of school. Do you agree with that?
Absolutely. And again, that's why I founded the institute, to complete with the knowledge that is not learned in dental school. You see, kids come out of dental school with very little knowledge about occlusion, and they need the knowledge, because what does a dentist do in life? We work on the occlusion every single day. I mean, you're involved in occlusion every day when you work in dentistry. Unless you're doing class 5 buckles on upper 7s only, I mean, whatever you do is going to be occlusally related. Remove a tooth, fill a tooth, do a crown, do anything, it's occlusally related. So you need to understand. The problem, I think, Howard, the problem is that the misunderstood part up to now was the joint. Because the joint does influence the occlusion. And in my 1 hour presentation that I did during COVID, that I could probably put on your site, I explain and show a lot of cases how the variation in the joint actually generated the bite shift that was creating the problems for the patient. And I got tons of cases to illustrate it. So what is misunderstood is that occlusion is not a static thing. Joints are not static. I mean, at our ages, we know that our knees and hips have changed. The temporomandibular joint also changes with time. So does our bite. Teeth don't just shift for nothing. The maxillas move. If you've seen a couple of years ago at a convention, I saw a guy give this presentation on an implant that was put on an upper central, and how the whole premaxilla in the next 25 years came down, but that implant stayed up. Our bones change with time, and so does our bite. So you have to, when you're involved in occlusion, you have to understand where those changes come from. And the joint is one of those origins of change. So you got to understand the joint to understand what's going on now. You got to understand the joint to understand what's coming in the future, and how you have to treat the joint, the occlusion for now and for later. I know this may sound complicated, but basically the whole system as a system was not understood as a system. We think of the joint and the bite as being separated. They're not.
I want to ask a question that's probably going to derail the whole train, but when you start talking about like orthodontics and stuff, there's a lot of people not in dentistry that are in anthropology saying, Man, when we look at Homo Neanderthal and habilis, and all, I mean, there's a lot of people coming out and saying we don't see any of this as little as like 500 years ago, and they're going back not far, but just a million years, and there's a lot of people saying that something's really happened to humans. Do you see that?
Great article in Scientific American came out just a few months ago exactly on that subject. An anthropologist wrote a fantastic article. I don't remember exactly which, I think it was November, the Scientific American of last November. Great article on that subject. Don't remember the guy's name. I wrote him and he answered. He was just a fantastic article. It started 250 to 300 years ago. The thinning of the palate, the shortening of the lower jaw. The displaced, well, actually, they don't have skulls with discs, so they don't know about the displaced disc, but that's one of the things we suspect changed. Yes, that our jaws are becoming smaller, and we're having airway issues and occlusal issues and joint issues, all because of something that happened, and there's something that's changed. Older skulls have great bites. They have big jaws. They have wide airways, full face. I mean, how many people do you know grew up full face class 1? I mean, they're almost non-existent today. They're a rare occasion. Most people are either a little bit class 3 or slightly class 2.
So do you think that's because the softer diet, eating mush baby food, or what do you think it is?
Well, whatever I think it is won't change what the truth is, but definitely that's a factor. Now, are there hormonal issues with hormones in our food? Are there other issues of pollution? Is that an issue? Is it just the diet? And a couple of articles have come out that changing diet in animals will produce malocclusion. So that's been studied. So to what extent is that fully true? I don't know. But definitely there seems to be an agreement that may be an important factor.
Okay. Another controversy. Abfractions. She graduated from school, and every time someone has abfractions, her mom fills them all in with composite, blah, blah, blah. And there's controversy on what even causes the abfraction, if it even needs treated. Some people that never treat them say, well, I've never treated them and nothing happened. So rant on abfractions. Are they connected to TMJ, TMD? What causes them? Should you treat them? What happens if you don't? Okay. See, what I do is I'm such a bad interviewer. I throw like 10 questions out there, hoping that one question is good enough for you to bite on.
Okay. Well, that's another noose for me to hang myself with. Abfractions, my feeling on it, and I don't have the total science and I don't have total knowledge, but my feeling on abfractions is that, well, I got them when I started having them on the, what are those numbers? I think 2 and 3 in the States. Number 1, 2, 1 is out, but 2 and 3. I had abfractions on those that appeared within a 6-month period in my life about 30 years ago when I was hyper stressed about something that was happening around me. And I was grinding like crazy, and that's when they happened. So I got like 2 millimeters of gum recession on those 2 teeth, and I got abfractions within a 6-month period of being stressed out. And I know those teeth were interfering back then because I hadn't been equilibrated yet. It hasn't progressed since my equilibration 25 years ago. So my personal experience, my anecdote of one, makes me think that there's a definite possibility that occlusion is a problem, is what is part of the problem. Is it the only problem? Maybe so, maybe not. I think there's a lot more research needs to be done on that. Typically, I do fill them because I've seen patients come in with abfractions and a virgin tooth and need root canal because the abfraction was deep into the nerve. So deep it was to the nerve. Patient needed root canal because of an abfraction. Could I have prevented it before? I have no idea, but I know I tend to fill them because I hope it's going to help. Was that
the mind, you can't teach a mind till it's ready to learn. And I have to tell young kids that I've been blown away so many times. Like, when I graduated school, no one ever told me sleep wasn't even an issue. It It never even came up one time. And then when I started learning about it a decade ago, then I started noticing every time I go to someone's house and they have kids, you'll see like a 6-year-old sleeping on the couch, just grinding away and can't breathe. And so then the question is, again, the same question, is sleep related to TMJ, TMD? Are they separate or are they the same?
That's been proven. That's a given. A retrognathic jaw is a problem for sleep. That is a given. Not all of them, but you have a higher risk of having obstructive sleep apnea if you have a retrognathic mandible. That is clear. And it's an extreme exception to have a retrognathic mandible without having the joint issue being there. And, we're starting to relate the fact that the TMJ disc displacement is at the origin of the short ramus that is causing the retrognathic mandible.
You're so fluent jumping back. I think is it because you live in a country that mandates French and English that you go from jaw to mandible? I mean, so many dentists that they talk to a patient, the patient doesn't know one thing because it'd be mandible endodontic therapy, but you just fly it back over to jaw root canal. I wonder if that's a bilingual. It's what?
Because that's the words the patients use. So
I know. I think one of the neatest things you can do is when you're over there waiting for your buddy to get off or whatever, he's in there talking to a patient, just turn your phone recorder on and then just go lay it on the table there and then send it to your notes person and that transcribes it. And then take a big black magic marker and wipe out every mandible where you didn't say jaw, and you come back and it's like, this is why the patients don't know what you're saying. I mean, they teach you Latin and Greek, and that's okay if you're talking to you, but not the patient. So then are you, when they have a retrognathic jaw, is your first thought to have orthognathic surgery?
That depends how old they are. If they're 72, definitely not. If they're 12, we're going to try to do something before they need the surgery. And if we can get the jaw to grow before the surgery, well, great. But it definitely is going to be a discussion with the kid and the parents that it might be an issue when they get to 17, 18, 19, or 20. Definitely. If you're 35, we're going to have a discussion about it. I mean, my role in life is to sit with the patient and talk patient as a language, and to help the patient understand what's going on and what are the possibilities for them. I'm not the type of person that will tell a patient what to do. I will give them their options. I will sit there with them, I spend an hour with every patient. Every new patient gets at least an hour with me. So we spend an hour talking. We look at the panoramics. We'll look at the bite effects. We'll look at different things, and we'll definitely chat things out and look at all the possibilities. Now, sometimes a 30-year-old just has 2 young kids. It's not the right time in their life to have orthognathic surgery. Sometimes it is time for them. Sometimes they don't really need it. Sometimes they do. Every case has to be assessed individually. But it's an option. And we'll talk sleep. As you said, 10 years ago, we started hearing about sleep a lot more. So everybody in my consult, everybody has I don't do a full sleep test. I don't do that. We're not allowed to do that here. But I will definitely discuss, are you sleeping well? And is there an obstructive sleep apnea possible problem? Then I'll send them out to their physician to get that checked out. So we'll check for the sleep. We'll check for the quality of the sleep. We'll check the stress levels. And then we'll check the diagnostics on the system. And then, yeah.
So what percent of the people in North America today that are on a CPAP machine do you think have been thoroughly evaluated dentally?
Probably not that many. Let's put it this way, not enough.
And how many of them do you think are connected?
A ton of them?
Yeah. Now, a ton. Remember, the average, I've done the math on that. That's only about 12 people. Ton's only 2,000 pounds. These Americans are getting heavier and heavier and heavier. But yeah, there seems to be so much overlap. And like I'm telling the young people, I mean, I never thought of the sleep apnea. I never thought of that issue when I got out of school in '87. So
Well,
it's
there's
a
nothing.
very fast-moving game that goes faster and faster. But I want to hold your feet to the fire on one question. If you saw 100 patients, do any of them get pharmacology? Does anybody get a prescription?
Oh yes, they do, because a lot of them walk in with severe pain and they need help with the pain, while whatever else we're doing to try to control the source of the pain. So medications, I use medications. I don't use a lot of them. I don't use medications very often, but there is a subset of patients that walks in and definitely needs medication. And some of the medication I won't even prescribe myself. I'll send them to the physician, because often these people are on other meds, and I don't want to be interfering with what's going on with the physician. So I'll write a note to the physician and say, I would need this. Can this be prescribed to the patient? And would this fit within their context? So I do some of the prescriptions myself. I use the physician for other things. But I'd say that probably less than 10% of my patients get prescriptions.
Less than 10%? And what would those prescriptions be, the ones that you write?
Well,
Are those 10% that need prescriptions all going to their family physicians, or are you writing any?
I will prescribe muscle relaxants, whatever the brand name be. So we'll use amitriptyline, so Elavil, whatever it's called in the States, which will help with pain, will help with clenching, will help with a little bit will help with sleep. We'll use other things to help a little bit with the quality of sleep. But basically, anti-inflammatories and muscle relaxants, those are my go-to things. The Elavil will happen a little bit less often, but I do go to it sometimes. I won't go to Lyrica or Neurontin or things like that. That'll definitely let the physician prescribe.
How would you answer this question that is very common on Dental Town? Remember, going back to that young girl, the age of my oldest, Eric, is 30 and yours is the same. They say, well, what lab do you use for TMJ? Meaning that someone has TMJ, they're taking impressions and sending them to a lab. So that's why I want to get really good in TMJ. So I need a really good lab. What lab do you recommend for TMJ? How would you answer that? And do you use a lot of labs? Do you only use one lab?
Well,
If you saw 100 patients, how many would need something from a lab?
Well, not that many now, because we've been printing our own splints. We scan the mouths, and we have a piece of software, and we have a printer, and so we print out our own splints now. Actually, I have, there's a lab that came to a lot of my courses. There's at least 3 or 4 labs that came to a lot of my courses, and that now are making splints in a fashion we've sort of done. In Quebec, we're a small group, like 5,000 dentists, and we're pretty tightly knit. And we have our Facebook group, and we're like close together. So the word went out really fast that when you make the splint in a proper way, it does get the patient's muscles to relax, and it gets their headaches down and things like that. So we have a splint that's a little bit more effective than others. That's the way I teach when I teach about effective splints. It has a measured efficiency of over 90% at reducing pain. So you take a CBCT and connect it to your printer? Oh no, we scan with a normal intraoral scanner.
Okay, so intraoral scanner. What scanner are you using?
The Trios.
The Trios from 3Shape. Okay,
yeah.
So you use a Trios scanner from Copenhagen, Denmark, and then what is the printer?
The printer is the Formlab.
Oh, okay, the Formlab.
Yes.
My God, you should do an online course on that.
Well,
oh my God,
that's in the discussion. That's coming. Yes.
Yeah. So they're gonna want to know, why did you go with Trio Scanner and instead of TrueDef? Well, first of all, TrueDef is gone now. 3M got rid of it, and we told them why before they bought it. You had to spray a powder.
I bought one and got rid of it.
And here's the deal. I had so many people calling me to quit saying that about it on this show, whatever. And the bottom line is, if that's what the market is saying. You don't, it's kind of like there's no raisins in Raisin Brand. So every commercial's there's 2 scoops of raisins in every box. Hey, why don't you drop the commercials and just put some damn raisins in the box? Wouldn't that be a lot easier? And instead of trying to tell everybody why the powder is no big deal, why don't you just remove the powder? But so it looks like 3Shape is walking away with the oral scanner for implants, all kinds of things like that. But if you're going to do clear aligners, seems like they're going with iTero because Align Technology that owns Invisalign owns iTero. Do you do clear aligners? Do you do ortho?
I do no ortho at all. None at all. I don't have the time. I get over 1,000 referrals a year just in my field, and I do not have the time for ortho. So I work with orthodontists or GPs that do great ortho.
And do you know the name of your Formlab printer, which model or anything like that, or not really?
The one I have is Formlab 2.
It's the Formlab 2?
Yes.
And what about your Trios?
It is the Move.
It's the Trio scanner, the Move?
Yes, Move. It's MOVE.
Yeah, and this is another request I'd like to tell companies, especially a shout out to GC, who I've been to your headquarters right there by Mount Fuji, but you can't call a product different in every country. It just doesn't work with the internet. Pre-internet, you could do that, but you can't have, because the dentists in Australia versus Belgium, when they're all confused, and I'm sitting there like, I'm reading this, and like they're all talking about the exact same thing. But the world has gone digital. I want to. Some people say, back in the day, in the 70s and the 80s, you were a rock star if you had your own business card, and now a lot of people are saying the new business card is to have a book, and you have a book, Becoming Your Patient's Hero: 9 Secrets for Creating Exceptional Trust and New Income for Your Dental Practice, by yours truly, and my gosh, it's by Donald Reed, forward by Peter Dawson, founder of the Dawson County. What do you think of that book, and what do you think of books like that?
Well, those little books are great. I mean, I wasn't the initiator of the book. I participated in the book, but those little books are great because there are a lot of people that will read them, and it's a short read, it's a simple read, it's quick. But you can get a lot out of it because you're talking about, you have a lot of people with a lot of experience in different areas saying things that can help out a lot of people. So those little books are great. And yes, that is a main thing right now. That is a fad. A lot of people are coming out with books now. That's true.
And I need you to comment. What do you think of Bite FX? What do you think of Bite FX? And the reason I'm asking, because I know he always talks about you a lot. But what do you think about Bite FX?
I love it because I use it every day with every single patient. It's a great piece of software to get you started in occlusion and joint pathology. When I did with you a few minutes ago explaining reducing, non-reducing, what do? I use my hands. No, you don't do that with a patient anymore. I have the software. It's up there. It's on the screen. You got the images of the joint, the disc and everything. It's moving. The patient say, Alain, thank you. At last I understand because the previous guy was doing this with his hands. So you need the software, you need the images, and they are working extremely hard to get everything right. So they've got the whole story, but they've got 75 or 80 different sequences out there, animations, and they're just fantastic people.
Well, the one image I'll never forget is if you look at a shark's, they had a shark next to a human, and the human's eyes, part of the brain, look like 2 tennis balls associated with the eyes, and then like 2 little cherries associated with the ears. And then there's other animals where that's reversed, but sapien, along with primates, especially our 2 first cousins, chimpanzees and bonobos, we're a totally visual animal. And if they don't see it, they're not going to understand it. And even when they're listening to radio, they need a sportscaster that can say it in such a way they can see it. But do you think I think visualization to a patient, if they don't know what you're talking about, I doubt they're going to part with $1.
No, definitely, absolutely. You got to see it. The patients want to see it. They love to see it. And often with the clicking joint, when they see the clicking joint on the screen, they point to whoever's in the room and say, that's what I'm feeling, and they relate to it. So that sells the case right away.
So now I want you to risk losing all your friends and family. I mean, everyone. When you're looking at these TMJ, TMD patient problems, how much of that problems do you think are iatrogenic from the dental profession versus how much is because they're a long lineage of primates and this is all natural? How much did we do, and how much was it's just life? It is what it is.
Oh my God. Okay. I've thought of that. I've tried to answer that. I don't think it's a question that for now it's actually possible to answer. If you want to quantify that, I'd have a hard time quantifying it. I'd say it another way. I'd say, how many patients are not being helped by what could have been done? There's a ton of them. Okay, there's more than a ton. There's a lot of those. So there's a very high percentage of patients that should be getting help through what our hands can do that are not getting it. I started teaching because of one of those patients who had been to 2 specialists. Actually, she had the orthognathic surgery and the orthodontics and was in worse pain after than before. I mean, she spent 2 years with the orthodontist and the surgeon trying to find ways to get rid of her pain. Took me a week with my splint. I mean, what were these guys not understanding? I just made, back then it was just a basic Dawson splint. She was out of her pain in a week. So what did I understand that these guys were not understanding? And why did it take a GP like me to get her out of her pain instead of the specialist? So see, it's not so much what we're doing that creates the problems, even though we are doing things that are creating some problems. Those do exist, but I don't want to accuse anyone. But what I'd like people to do is get the knowledge to understand what they can do that can be beneficial to the patients. That's where the name of the game is. Get all these people, okay, forget about what we're doing that's wrong, so because we've been doing it, and let's not feel guilty about it because we weren't educated about it. But what we can be responsible about is what we're going to learn and what we're going to do next to help these patients. When mouths are breaking down, see, Howard, a lot of premature wear on teeth comes because the people are lopsided because the joints are lopsided. There's more pressure on one side, so they're breaking down one side more than the other. Not necessarily because of parafunction, but because that's where the bite shifted to because the joint's bad on that side. And how can we help those patients? Because most dentists will just see the broken down tooth and just make a crown. And then that tooth will hurt, so they'll do a root canal. And then that tooth will break between the roots, and then they'll do implants. Then the implants go bad. And what's the problem? When you take an MRI, you see that the joint is really small and all the pressure's on that side and was just not assessed. It wasn't seen. So did that dentist hurt the patient? No, that dentist tried to fix the patient, but that dentist didn't do anything to help the patient. That's where I think we need to go from now, because a lot of that is happening and a lot of wear and tear in the mouth comes from ill bites. And again, not from parafunction, but from the bite being off in a manner where there's more pressure on one side than the other, or more posterior, more anterior. And that's the part that's breaking down the most. So once we start understanding the relationship between what's going on back here and what's going on out there, well, then you start understanding what you can do to help the patient to stop the destruction of the mouth and the premature wear and the headaches and everything that can happen from that.
I'm sorry we've gone over an hour, but can I ask a couple overtime questions?
I am there for you. You end this when you know it's done.
Okay. Arthritis. It just seems, I don't know if it's because I'm older and I'm seeing a lot more of it, but how much does just regular flavor arthritis play into all this?
I don't see many arthritis patients with joint issues. So I've seen a couple, but arthritis is not a temporomandibular joint typical problem. Osteoarthritis, where you have degradation of the joint and wearing down of the joint, you have a lot of those. there's other conditions like osteochondritis dissecans or some form of avascular necrosis that goes on. So you do have bone issues within the joint, but arthritis per se, it's a systemic problem, and I don't see much of that.
So then what's the difference between arthritis and osteoarthritis?
Okay, osteoarthritis is a localized problem. It happens when two bones rub together and you lose the cartilage surface over the bone, and then you have dimples within the bone itself. That's osteoarthritic damage. That typically happens when the disc is off the condyle. It happens sometimes with the disc is on but partially off and creating a pressure point, but that typically is a pressure point problem. It's wear and tear from overwear.
Again, my goal is to make you have no friends. What is your comment on the NTI? That's a big brand name in the States. Very common question. What would you say to someone says, do you recommend treating TMJ with an NTI?
Treating TMJ with the NTI is no. The answer is no. Treating muscle spasm with the NTI, the answer can be yes. There's an enormous difference between the two, and we'll be here till next Thursday if we start getting into that. But there's a difference. The NTI has been demonstrated to reduce muscle spasm. Yes, that's true. It has downsides. It has upsides. It has downsides. Personally, I typically do not use them long term. I will use them short term, but it has downsides, so it's not as good for the patient as a full coverage splint that's well made. Now, it will be effective at reducing tension and tension type headaches in a lot of patients. Yes. Should it be used long term in a lot of patients? My personal opinion is that probably not, or if so, with a lot of surveillance on the patient. You want to see that patient regularly to make sure things are not happening. But you see, the picture's larger than that. It's typically not just muscles. The muscles are not firing because they're just on their own. There's a reason, and usually there's a structural problem too. And the NTI does not address that structural problem.
Are you considered in your community? I mean, when you're busy, you're booked, you're successful, are you a headache migraine doctor, or is this why people are talking about you on social media and coming down and they're calling your receptionist saying, does he cure migraines?
I manage migraines. I can't say I cure them. I did a little pilot study with the Montreal Migraine Clinic about 20 years ago, and the neurologist invited me to do things with him, and we did occlusal equilibration. Well, we presented that in Chicago at the AARD. Some people do come to me for that. It's not the mainstream patient I have, but some people do come to me for that. It's a percentage of what I do.
So it's a percent. But would you say small, medium, large, not the main thing?
10%, 12%, something like that, 10 to 15.
Oh my gosh, I could go on and on and on, but you're 3 hours ahead of me. I really would. I try to get great information to my homies, and my gosh, I really wish you would turn the community on with an online CE course to learn more about this, because it's kind of underweighted in dental schools. Now, all my dental school deans that I drink with, they say, "Come on, Howie, we're taking a kid off the street from scratch, and we got to turn them loose on the." They just say they just can't teach them everything, and it goes on. So I got my final question. This is the dumbest question you've ever got, so our family, it's third generation wrestling. My grandpa got me into it. My four boys, our garage was just a wrestling mat the whole time. And my boys always ask, how come in boxing and MMA, how come the shot, right on the money shot, right on the jaw, something electrical's happening because they just black out. And you could hit them much harder in 10 other places, but why is the money spot the end of the jaw?
I don't know that one. I know that.
Did I stump you too? But it's but I've actually gone to many of the fights as a dentist, and I asked the guy in the trainer. He goes, "Well, if you hit him right there, it's lights out." I know, but why?
Well, I've met GSP a few times, Georges St. Pierre.
Oh, my fave. Oh, my God. What a class act. What a monster. What was he like in person?
He's a great guy. He's such a fantastic guy. Oh, he's nice like crazy. You want to have a drink with him. You want him to be your buddy. Yeah, of course, we all want him to be our buddy.
What a class act. Legend.
But this guy has a severely injured jawbone. The only reason I can think is that your temporomandibular joints, the condyles, are at the base of the skull and right in the middle. So if you get that hit, you're transferring impulse directly to the skull. So that's the only thing you can imagine why a blow to the jaw will actually knock you out. And
then I want to say one other thing about the boxing, which I don't want to say, but you know, in boxing when they're bleeding real bad and they put that stuff on to make it stop bleeding. It makes the astringent we use like I've often thought about starting a boxer's astringent supply deal, but amazing. So do you think he'll have a lot of problems when as he gets older and older from being in a war zone like that forever?
Well, maybe yes, maybe no. Who knows? Time will tell. He's at risk, but what'll happen, nobody knows.
All right. Well, hey, man, thank you so much for coming on the show. I learned so much. This is a weak area in dentistry compared to cario perio, and you are a class act like Georges St. Pierre, or how do you say his name in French?
That was perfect. That was
really,
perfect.
really.
Absolutely.
Oh my God, my all four of my boys, we all love that guy. He's just amazing. But thank you so much for coming on the show. And next time you see George, have him hit you right on the side of the jaw. And maybe if you experience it a few times, you'll figure out what's causing it. But thank you so much for coming on the show.
My pleasure. Thank you for having me, Howard. Thank you very much. It was an honor to be here. It was a pleasure to be here for you guys.
Thanks, man. And we'll talk to you later.
All right. Take care.